morning, everyone. Welcome to an AIHI seminar series presentation by Carrie Marr, the CE of the CEC. I've used jargon and acronyms already, haven't I? The Chief Executive of the Clinical Excellence Commission. I'm Geoffrey Braithwaite. Welcome to this particular seminar series edition on creating learning systems for quality improvements. Carrie's going to speak shortly. Carrie, welcome, and thank you for accepting our invitation. Just a short anecdote. Carrie, you have seen her CV, which is extremely impressive, and especially her work in Scotland, in Tayside. So we were chatting over some coffee the other day, and I said to Carrie, you know, you've got this big job, and, you know, running the CEC, I knew a couple of your predecessors, one of whom's in the audience. It's a huge job. You must need time out sometimes and have some holidays. And as some of you know, I'm not sort of prone to inviting people to go on holidays. I'm more prone to saying to people, work harder. But anyway, so we got to talking, and Carrie said, yes, I'll have a couple of weeks break soon. And she said, what about you? And I said, yes, I'll be on leave from the 28th of December till the 26th of January. And she said, where are you going? And I said, oh, the UK. I'll be spending time in Scotland. And she said, aghast, coming from Scotland, you're going to be in Scotland in January? And I'm going to be in Sydney in January? Are you crazy? So thank you for that tour information about not being in Scotland in January, but I'm still going. Yeah. Carrie, as you know from her CV, has done some amazing things already in the time she's been with the CEC, but she's got a long background in health systems improvement, in quality and safety in Scotland. We're going to hear from her now. Could you welcome her to the AIHR seminar? Thank you.
Thank you for that warm welcome. The kind of conversation I wanted to have with you this morning, when I first got Geoffrey's brief, was to talk to you about what our line of sight is around safety and quality over the next 2 to 5 years, and thinking about what's ahead of us. We're in a privileged position because until I went for my coffee this morning, I didn't realise that the founding member of the Clinical Excellence Commission is in the audience with us. So you get the privilege of being able to think about resilience and sustainability in healthcare from both of our perspectives today. And so I hope that means you might want to think about where we've come from as well as where we're going. Because for me, organisations and countries go through cycles. And each time we go into a next phase of maturity, we build on where we came from, because that's what gives you the incremental lift to go to the next phase, isn't it? And I don't want to speak for Cliff, but when I came to the CEC last year, and I had my 1-year anniversary last week, when I came to the CEC a year ago, what was evident to me was the 12 years at that point when I came of work that had gone in to setting the foundations for that safety improvement effort. And we followed a pattern that internationally other countries have also followed. We've grown our safety and improvement effort in the beginning from adverse events, from learning about things that we could have done better, and thinking about how we create a focus in healthcare systems to look at things like sepsis and falls and deterioration, and thinking about how people feel confident to deal with them. And because the Clinical Excellence Commission spent their early days and years building those great foundations, what it means is now in this next phase of 10 years, that we want to then think about how we grow that and think about systems. And we couldn't do that without having the first phase. And if you look at Scotland and England, particularly a lot of the Scandinavian countries, that's exactly the same pattern that we've all followed. That we get that transactional competence in our systems, we understand what that knowledge of improvement needs to be, and with with that kind of change always comes some disruption, a different sense of vision and focus, and you'll get that when anybody new comes into an organisation or a ministry. But what that also gives us is an opportunity to rethink and refresh what's our next stretch, where do we want to go, and of course the question that people like Cliff and I and Jeffrey keep asking people is, and how courageous are you prepared to be? Because we can all have a stretch challenge, but we might not be as courageous as we really could be. And so that's part of the question that I believe is our responsibility to ask. Some of this is about being safe, but there's also a need to think a bit more radically about what we'll need to do in the future. And I'm going to talk to you today a lot about hospitals and healthcare within that hospital model. But the other thing that's becoming really apparent in the reform conversation is, as we start to move more and more into integrated care, into thinking about how we deliver mental health in the community setting, we're going to have to think about how we adopt this model across whole systems. You've seen that work in New Zealand, and certainly that's the approach we took in Scotland, quite different from England. So there's a really interesting time, I think, in New South Wales' journey. And one of our intents in this next phase of work is actually to get people thinking about quality as a habit. And when I talk about the word habit, what I mean is instinctively people believe it's the job, right? It's not something extra. It's not in addition to the PD. It is the job. And you know, if you go to Kulturum in Sweden, they say everybody's actually got two jobs. You've got your job, which is quality and improvement, and you've got a second job, which is every day to come in and improve your job. A very strong philosophy that responsibility we all bring to bear, that when we come to work to think about what we can do better and different every single day. So there's something about quality being something that we know we should do every day, and something we should practice in everything we do. It becomes instinctive. We're doing it because we know it's the right thing to do. And some of us had the pleasure last week of meeting with Peter Pronovost from Johns Hopkins and listened to the story of where they've got to in Baltimore. And it's quite clear that one of the things that's made Johns Hopkins successful is that they have instilled in their organisation, from the bedside to the boardroom, really consistent, reliable work practices that actually create that sense of reliability in their system. So we want to think about what those work practices are. And what was really interesting is for the first 20 minutes, all Peter talked about was culture. Yeah? Didn't talk about anything else. He just talked about how for organisations to thrive, to become resilient, their conversation about their values and their culture is fundamental to that happening. And so my invitation and my reflections currently are whether we need to do more of that in New South Wales. So these are some of the issues that we are dealing with. We've been looking at the work that we've been supporting in New South Wales. There's some fantastic innovation has happened in New South Wales. And so we've always, and we remain continuing to have a commitment to quality. But our sense is that if we could just take the great innovation and go to scale, we would actually be helping to create more reliability in the system. So there's great pockets, but when I go into a hospital, is it in every ward? Is it in every department? Is it in every facility? We're not there yet. And that is the biggest challenge that all of the international community have always had. How, when you start to embed this work, do you actually move it so it's something that becomes a systems property? Not just the property of one ward with one great leader. Yeah? How do you create that system leadership? We've also recognised that there's a bit of a gap nationally in how the kind of agencies, the pillars across New South Wales work together, and how we work with the ministry and how we work with the local health districts, and that there could be a tighter way of us aligning our work so that we come together with a more cohesive offering of how we can support e-health and how improvement can support safety and how safety can support flow and operational performance. And we see some opportunity for us to join the dots on that. The other thing that we've reflected on, I'm going to talk a bit about this in a minute, is when we've asked the system where the balance is, their sense is that we are erring a lot more to compliance than improvement. I'll talk a bit about what that means in a minute when I lay that out for you. And the priority thickets is just that sense of reality in healthcare. Everybody has got a plan, and everybody's got a plan with a lot of actions in it and a lot of objectives. The system is feeling as if we're overwhelming them with priorities. And they're almost asking, and Jeffrey and I were talking about this earlier, they're almost asking for permission to focus on the 10 things and not the 100 things in order to really do them well, as opposed to superficially trying to do good across 100 different things. In Scotland, we used to call that approach spray and pray, that you'd so many priorities to do for your government that everything got a little bit of your time, but nothing went deep, you know? And so our responsibility is how can we declutter the landscape? And one of those is around data. So if, we've looked at some of the wards, and in some wards, in some hospitals, we've got nurses collecting what is the equivalent of 37 hours worth of data. And that's just in one ward, in that team of nurses. Now, they're not using 37 hours worth of data. So there's part of that is how can we declutter the data landscape so we're collecting the right information and the right metrics, and we're using it for the right reason. You know, there is this philosophy you should collect once and use often. And at the moment, the sense out there in the system is we're collecting often and we're using some of it some of the time. It's not particularly an effective way to do it. We've also recognised that we need to have a much more planned approach to capability. Internationally, there is a formula that we use in healthcare systems to help us work out the critical mass that we need for improvement. And I've certainly for the last 10 years used the Kaiser one. So in a given staff population, 0.5% of all of our staff should be trained as improvement experts. So that's full-time people, quality, safety, redesign, improvement, quality assurance. All of those people should be trained as experts. And if you take an average metro LHD in New South Wales, that would be about 60 people, full-time, trained, coaching the system, supporting the system in those roles. And behind that, the next part of the formula is that in that kind of cohort of nurse managers, clinical leaders, that kind of middle part of the system, we should have 15% minimum of those individuals trained to lead improvement and safety work. And in a metro LHD at the moment, that's about 2,500 people in every LHD. So when you start to multiply this up by 17, you're starting to see the challenge that we've got in our hands and how incrementally year on year we can start to build a critical mass of people that we can use. Now already, if I just look at the clinical leadership programme that the Clinical Excellence Commission launched many years ago, we now today have over 2,000 people across New South Wales who've been through the programme. But quite a lot of them are frustrated because when they go back to their organisations, we're not deploying that expertise. We're not using the skills of people that come out to do that kind of skills development. And so before we even start, we've got an alumni across a number of programs we actually need to start using. And I think for organisations like this, how could you connect with some of these people? They are hungry to get involved. And we saw last week at the GMO conference, we've got 400 GMOs in New South Wales who are hungry to work with all of our organisations. So how can we use them? How can we engage them? And the last bit about capability is that there is this proposition that every single board member and every single executive director needs to be trained in improvement science and measurement. And if we do that, we would fundamentally change the conversations about what governance means in quality and safety. So we've got a bit of a challenge there. Local accountabilities, I'll talk a bit about at the end, which is, do we need to rethink what the role of a board is, the role of a chief executive is, in providing that system leadership and permission to make this happen, and how do we support them to do it? And then lastly, the chestnut of measurement and reporting, because we are still challenged by how real-time our information is and how quickly we are getting it into the hands of clinicians who absolutely want today to know what's going on today, not what went on a year ago. And we need to think about that. So we can talk about it. So I was going to just reflect on some of the things that I've used up till now in my reflections on system performance. Way back in 2009, when I first listened to Anthony Staines at Berlin, we were 3 years into our patient safety programme in Scotland. We were starting to get some traction, but we hadn't really thought about the systems component of making it stick. And Anthony did his PhD in systems performance and resilience around safety. And there's a whole presentation which I can share with you through Jeffrey to look at. But effectively, even in those early days, Anthony was talking about the characteristics of great organisations. And in 2009, it was the organisations that were in the top quartile were Intermountain in Salt Lake City, Kulturum in Jönköping in Sweden, and the third one in 2009 was René de Graaf in the Netherlands. Now, if you were looking at that top quartile today, interestingly, we're now 7 years on, Kulturum and Intermountain are still in that top quartile. They're doing something that sticks. They're doing something that sustains. They're joined now by the Cincinnatis, by Virginia Mason, by Kaiser, by Salford in England. There's a whole lot of other organisations have joined in that top group. But it's interesting to see how some organisations have sustained that level of outcomes around improvement and safety. And what Anthony said way back then was the characteristics that he saw in those top organisations were in those 4 domains. They were in leadership and culture. So what was the strength of the leadership? Was the organisation orientated to measurement? Did they understand what mattered to patients? Were they connected to stories about their patients, not just the data? What did the leadership bring to support the front line? They were also, even in those days, Kulturum had an academy. Intermountain was doing its advanced programme. They were setting up very planned approaches to creating the critical mass. They all had really good data and information systems. And if any of you have been to Intermountain, you'll have seen how sophisticated and real-time their measurement system is. But really importantly, what his piece of work way back then demonstrated was the other difference in those organisations who were really good at this. Apart from those other 3 characteristics, they focused 90% of their attention, their resource, their coaching, their support right on the microsystem, frontline. They fundamentally believed that in order to be strong and resilient, that actually you had to understand that all improvement is local. It doesn't happen in boardrooms. It doesn't happen in committees. It happens where people touch patients. And therefore, they designed and organised themselves to make that happen. Really fundamental proposition. And I hope we get a conversation today about just what that might mean for us. So that was way back in 2009. And then we've got our more recent reflections with colleagues that you'll know in this room, looking still at what that rich tapestry of a high-performing hospital is. And you know what? It's not different. That sense of connection to your values, your culture, how much your staff feel engaged in their effort, what leadership you bring to bear is still there. So, I suppose the reflections for those of us who've been in healthcare for a number of years is the proposition here is not difficult. Making it happen is. Because what we're talking about here is hardwiring a way of working and a way of being into the fabric and the culture of an organisation that's going to create the conditions for change. I was speaking to some middle managers last week, and we had a great conversation about the challenge of what I was inviting them to think about is surely the job description of everybody in the middle part of the system is that your job is to create those conditions. That's what the job description is. But how much time do you spend doing that? We're caught in a bit of a hamster wheel of doing what we need to do as opposed to doing what we want to do. And how can we create some space around that? So this hasn't changed. When you look at the six focus points for Kaiser, it's the same. So we've known what needs to happen. What we need to do is think about across New South Wales how we connect all of this into our conversation about systems leadership for safety and quality. This is a framework that I've been using since I came into post because I was introduced to this initially by a gentleman called Alan Frankel when he was working for Pascal Metrics. And in the year, I've been going around each of the local health districts and networks and just finding out from staff where they think New South Wales is. And interestingly enough, almost everybody I've spoken to has placed their pin that it feels as if we're sitting between reactive and systematic. In some parts of the system, they're feeling more in the reactive, much more in the reactive. Some of them feel they're lifting a bit into the systematic box. But everybody's feeling that we're doing something that's not proactive and not predictive at the moment. And so part of the proposition for us in this next phase is how can we build on what we've done and now help people to think about how you become proactive? Because when you start your journey, it's absolutely the right thing to do that you focus on the things that we're not getting right. How do we create better outcomes for patients? How do we look at all the error in our system? How do we find out the defects, the unreliability? How do we source that and deal with it? But if you want to move to the top part of that framework, you've actually got to look at the fat end of the wedge, not just the thin end of the wedge. And you've got to understand what you do right most of the time in order to replicate it. You've got to understand when you do get it wrong, how you deploy everybody to make sure that you deal with it quickly. So you become much more agile rather than feeling that you're bogged down and being reactive. And people are feeling at the moment, we are feeling quite reactive. We are engaged in a number of processes that keep making us look back, not forward. And so our responsibility is to think about how do we lift some of that. And we can have a chat about that later on today. How do we help organisations think predictively about the harm that could happen today and tomorrow, not why it happened yesterday? Okay. And part of that proposition then is to think about how can we bring some balance to bear on this? Because the reason people are feeling that they're in the reactive box is because they're feeling that we're spending all our time in compliance. And you know yourself in healthcare, we define ourselves by process measures. It's how much, how many, yeah? It's volume, not value. But what people are asking for is how they can bring more of a 50-50 balance to spend as much time in the right-hand side of that proposition as the left. So we still need compliance. We need standards. We need to standardise our practice in healthcare, and we need to support people to do that, every patient, every time. But we also need to give people the chance to improve past that standard, to actually think collectively about how they could do more, and actually bring more innovation to the workplace. Because the challenge with only sitting in compliance is you can stifle innovation. You can stifle the very things that your staff want to bear. So our intent is to try and get this more 50-50, and that hopefully will help us lift that as well. And if we were more 50-50, what would we know? Those 4 questions would be much easier for people in the front line to answer every day, because at the moment they're not able to answer all those questions. And yet in the world of improvement, that's the fundamental conversation that we believe teams should be having, right? So, do you know how good you are today? Not last year, not yesterday, today. And the private sector have got a lot to teach us about that. If I was the manager of Coles supermarket, I would have the metrics in front of me at 12 o'clock every day that would tell me what was going on. We need to think about the same level of agility for our clinical teams in healthcare. The second one's also really important, because you also have to understand where in your system, in your department, in your service, do you know, because you're looking at the data and you're talking about it, do you know where your waste is? Do you know where you have variation that's unwarranted? And do you know how much harm you have in the system? Do you know how many patients that have had a bad outcome? Do you know their names? The challenge here is we need to get past people thinking just about statistics. They need to understand that every data point, particularly when we talk about variation and harm, has actually got a patient at the end of it. And how do we do that? I have a colleague that I've known in the States that we did some work with in Scotland called Jim Conway. And Jim Conway was a chief executive and then became a chairman of a board out there. And at his board meetings, he actually shared the names, the first names and the age of everybody in their system that he wanted the board to know had died a preventable death. He made it really personal. Every board member went out that room thinking really differently when they saw a conversation that said Annie 6 months and John 43 years, and not just the number of adverse events they'd had in the system. So how can we think about really making this personal? How we compare best in class. So there's 2 levels here. It's great to compare ourselves with who's on our doorstep, and we should know how we compare across Australia. But actually, if we're being really brave, we need to be prepared to compare ourselves internationally. Yeah. We have a few daft sayings in Scotland, and when we used to talk about this, because we used to love comparing ourselves to everybody in Scotland, particularly as the organisation I was in was the top performing board, and then somebody said to us, "But you're just the cream of the crap. You're not being brave enough. Be prepared to compare yourself with people who are going to stretch you. It's not good enough." So it's just be brave. It's a stretch challenge, but be brave. And do we know our rate of improvement over time, which is how are we tracking what we're doing in safety and quality? Where are we tracking it, and is it on the walls? My ambition would be, wouldn't it be great if we could walk into every department and ward and see the data on the wall that tells us how we've improved outcomes for patients? Yeah? Patients love it. They want to know how many days since the last fall, how many days since someone had an infection. They want to see that you're showing your rate of improvement about how you're delivering care bundles. And they want to see their feedback about what matters to them as well. And the whole learning board is taken off. We've got whole districts this year who are trying to put up on every wall boards that their staff and their patients can see what they're focused on and what matters to them. And just making it more visible and transparent will actually change the culture. Yeah? And gets everybody talking about it. If you have a huddle every shift around your board, you're focusing on what matters to you that day. So, lots to offer there. And the other reason I think we're also in a bit of a tipping point is historically healthcare loves to kind of sit in the world of performance, We love a good performance plan. We love a good action plan, don't we? But performance needs to if it's going to mature, we need to move past just looking at performance, and particularly financial performance. We need to look at improvement. Yeah? And how do we do that? But if we grab this, the other opportunity is we then go to the third curve. And the third curve is actually we start working across communities. We start working with agencies that are not just in health. We start thinking about working with our local citizens in a fundamentally different way. So if you look internationally about how early years has moved on, early years, and it's starting in New South Wales, the conversation in the last 6 months has changed. We've got agencies in the room who would never have been in the room together a year ago, talking about a joint purpose to improve outcomes for early year children. So that improvement methodology that we bring to bear in safety, we can use that and share that with other agencies who've all got an interest and have a joint purpose in children, in elder care, in areas like that. And I think you'll find that you're going to see much more visibility about how we could do that in New South Wales. So I'm going to see all the chief executives in New South Wales tomorrow. And this is the question I'm going to ask them. Because I think there's a fundamental difference between administering safety and quality as a system that you feel you've got to do, as opposed to embedding it as an operational management system, right? It's very similar in thinking to the philosophy of John Hopkins, that if you hardwire this in a different way, you're leading it, you're directing it, you're giving permission for your system to engage in it. You're not just taking it on as a task. And how do we actually create the shift change we need in order for organisations to do that? So we're thinking of focusing on 5 things, and we're going to be testing this out with the systems. If we really want to think about system leadership, then we believe that we need to be talking about these things. The first is psychology, and that's about helping everybody in the system understand how we affect change. Right? We don't affect change through policies alone. We don't affect change through regulation alone. Behavioural change comes from a very different set of supports. And how do we make that happen? We need to think about who we're going to work with in the system. And why I've put the adoption curve under there is, I'm a great believer in just spending your time where you'll have most impact to start with. We start by spending our time on the left-hand side of the curve. We pull together our clinical leaders who want to get involved. We pull together staff and frontline teams who want to drive this improvement, and you work with those who want to do it. Because you will have some who want to sit on the fence and they won't come off until the first group show them the data that has made a difference. And that's okay. Because if we got everybody to jump at the same time, we just couldn't manage the support of the system. So, I'm quite happy for that to be incremental. But we need to think about how you support and nurture people who really want to be in the adopter end, who want to test, who want to prototype, who want to support, because they're going to need support from their leadership to do that. So we're actually testing the will of the executives in the districts where they sit on that curve, and how we can bring them to bear in making some of this happen. The systems approach is what I've talked about. It's about understanding that you actually need to think differently if you want to engage in a conversation about improvement and safety being a systems property. It doesn't happen just at a point of care. We're all connected. And how do we bring all of this together in a systematic way so that we actually probably need to consider whether we're really developing leaders in our system to understand systems, yeah? Our complex, adaptive systems that we work in every day. We are not running a production line. We're running something that creates value. It's got a human dimension. So therefore it's messy. It never goes to plan. And you know, one of the big challenges for leaders in systems that are complex, adaptive and messy is it means you need to support people to work with emergence, to work in that area of grey. Working in healthcare is not about working in the black and white. And the more senior you become, you realise how little you control. But that actually needs to be something that we support and develop in people as a confidence. The third bit is about, as I talked about, the data. So how can we focus on and invest in the systems that are going to get real-time data and its analysis in the hands of the people who could use it best? And how can we do that quickly? And lastly, our theory. Because if we're going to go to scale, we need a method. And at the moment, people have got will. You know, one of the things that brought me to New South Wales 3 years ago was when I talked to the clinicians in the system that I came to, there was clearly will in the system. Great people here who want to do the right thing, and they understand why. But most people are saying, but we don't know where to start. We don't know how to do it. And so we need to create a method. The model of improvement, looking at establishing collaboratives, getting people to start sharing what they're doing across organisations. Because we're quite siloed in healthcare. We love keeping to ourselves what we're doing. We'd fly to another country before we'd knock on the door of the next LHD. That's just the phenomenon of how we work. We would do the same in the UK. We would go to America before we would knock on the door in England. But that's a Scottish thing, isn't it? But you know, how do we create more collaboration? You know, there's 6 different hospitals want to work on sepsis. Well, come into the room together. Let's talk about it. But this bit at the bottom again, and how can we use all of those 4 lenses to support the front line in a way that's going to make this happen quite differently? And the other thing I think we need to think about, and will definitely make a difference, is whether we're prepared to hold lightly the way people work. Because the difficulty with big, unwieldy mechanisms like health is we're perfectly designed to take 9 weeks to make a decision. Yeah? We have a working group which can last from anything to 3 months to one I found in Scotland that had been going for 7.5 years. And it had still not had found a solution to uniforms or car parking. Surprise, surprise. So there's the working group, and then you've got to go to committee, and then you've got, we create so many hoops for people that people don't believe we're making it easy for them to have a great idea, test it, and get some permissions in the system. So we need hierarchy, because we need a sense of how we make decisions, how we govern ourselves, so we need that. But the proposition, and if you read some of the works of people like John Cotter, his proposition is that you need to create networks in your organisations so people work horizontally. And you need to allow people to engage in networks and not know what they're doing. Let them go free, let them have great ideas, let them spontaneously combust. Yeah? In different departments, across different organisations, and let that grow, because if you allow that to grow, the energy for your improvement and safety work will actually stay there. And that will keep your resilience alive. It's part of what should be in the fabric of great organisations. If you look at the ones, the private sector that work really well, they create this really, really well. Virgin are a great example of that. They do this really, really well. So these are the 5 things this year we're going to focus on, because we're about to embark on a 5-month journey to develop a New South Wales framework for quality and safety. What are the components of that framework? We're going to talk to people about those 5 things, as I've said throughout the morning. What governance and accountability processes do we need, and how are we going to establish them? What is the leadership and culture that needs to be brought to bear to create the conditions for change? How do we build the right capability that we need in the system? What are we going to do to ensure that we have the right metrics from the bedside to the boardroom to the ministry that assure us that we're doing the right thing and improving the right things and spending our time on the right things? And lastly, this whole piece about creating reliable microsystems. So we want to get into a conversation with all parts of New South Wales over the next 5 months, and we'd love you to be part of that conversation. And if you want to do some thinking here with Jeffrey and colleagues and come back and give us your thoughts and ideas, it'd be fantastic to come back and continue that conversation with you. We want to, on the back of that, then think about how we form a plan to support the system in those areas. I think we've got a real opportunity. And I think we'll find that we've got a massive community of people out there who really want to do this. And if we can show them the incremental steps, particularly in the first year or 2, to get going, I think we'll get to a point where New South Wales will be in a place of confidence to move into that next phase of maturity. That it's taken on board everything that it's learned in its first phase of work, and it's going to use that and this kind of conversation to leverage it into the next phase. Thank you. I think that practice is not a consistent one. I think it would be fair to say that boards, because we don't have a process that we ask them all to follow. What we do expect is that every board should be talking about safety and quality in every board meeting. And actually, if you follow the direction for boards, there is the proposition that it should be the first thing on a board meeting, and that money should be after safety and quality. Every board meeting should start with a patient story. So the orientation of a board to understand what's happening in the system should be strong. Now, one of the things that I think we want to talk to the boards about is how much of that's happening in the boardroom and how much of that is being delegated down to the subcommittees for quality. So every district has a subcommittee across the district for quality and safety, which look at all their metrics, which bring together all their clinical leaders, and they're fantastic groups to think and reflect on where the system is at with that safety work. But in addition, the boards should all be talking about it. I believe every board should know about every significant adverse event that's happened in their system. I think that leadership needs to come from boards. So part of what we want to do here is talk to the CEs and the chairman about whether we need to is there anything that we could do to support or tighten up that role of boards, of executive teams, and of clinical governance units, because there was, there's been some great work done to look at the role of clinical governance, but we're at a point now it's looking a bit different across every system. We think we need to revisit that so people understand that clinical governance isn't responsible for quality and safety. It's there to support and help the clinical community take responsibility for safety and quality. We need to think about how we do that. So it's going to be part of this, it'll be in the governance circle. So we have an opportunity around the data. You know, there's nothing less, there's nothing that's more demotivating than to put effort into collecting something and you don't know you don't get any return on it. It's one of the reasons in the new incident management system we are providing more functionality that when you report an incident, you're actually going to get feedback about what happens to it. People like the feedback. I think it's very hard for people at a local frontline level to decide what they're going to stop because it feels as if it's coming down the system. I think it's for the leadership of the organisation and for us in the agencies and the ministry to make a view on that. I think we need to think about whether we need the process measures that we've got and if we can take some of them out. I think we need more agility in being flexible about what we measure. So at the moment, if you look at our KPIs in the system, so we've got a KPI for hand hygiene, we've got KPIs for central line infections, for instance. We've got hospitals who, because of the great early work on the CEC programmes, have actually been without a central line infection for 13 months. So, you know, my question is, well, why are we still measuring that? So the stuff that's going well, we should be able to drop and measure much less frequently, and you allow teams to put up there something that needs their attention every week. But you've got to give people permission to do that, you know? You know, our hand hygiene is 84% across the state. It's the best in Australia. That's fantastic. Well, let's drop that, report less. Let's put something up that we really want to talk about, like the rate of falls. You know, so I think what we want to explore is whether we could have some overarching indicators that we would like to see at a state level. Now that might be things like mortality. It might be things like significant adverse events, but allow the local systems to decide what's the 4 things you want to work on in order to feed that big dot. Right? So over here might want to look at sepsis and deteriorating patient, but actually over here might want to look at pressure injuries and falls and other things. So we're getting quite a good response from the system to do that. We're going to explore that as part of this conversation. But I think if we're going to get people to take ownership, we actually need to give them some room to decide what their local priorities are. And so I think there's room to do that, and then keep our eye on the big dot. Look, I think there's an opportunity for us to bring these two worlds together. Historically, we've had research and we've had improvement, haven't we? And people have felt that they've actually had to make a choice. Do I go into the improvement club or the research club? I think the conversation that's been emanating in New South Wales is a fantastic one, because we're all starting to talk about implementation science, the space that bonds us, and thinking about how we could actually have researchers and improvement experts working together. I think opens up a whole space for us to think differently. I would love to see more researchers on the ground as part of these teams, particularly because I think there's a challenge for us that work in that world of organisational development around this, because it's really hard to measure culture, as we know. There's so much work being done on it, but how are we really going to show that we're making that difference? And how do we demonstrate that back to the system? I think if we could show more partnerships that we could create, I think we demystify the whole research improvement conversation. And neither of us are in it for judgment. And that's the other thing that should bond us as well. So I think, you know, we should think about some things we could be doing now, because the other thing I would notice is we need to start right at the beginning of some of these new bits of work to think about how we demonstrate over time we're really showing the shift change, which means we should be talking now, not in a year's time. So any ideas? CEC would love to come and spend some time with you and bounce off some ideas. accreditation framework and the standards, when I worked in an LHD, they were fundamentally at the core and the heart of what we were doing. And we would use them, and we would talk about them in terms of how we wanted to develop our practice. But what I would notice is we've kind of got two parallel lines running at the moment. And so in that accreditation stream, we've got teams who intensify their effort around accreditation, normally in the lead up to the survey. And we have this 6 weeks of industrious effort, and then it kind of stops. And then over here, we've got all this safety and quality effort. My ambition, and I would love to think about how we could do this, and I think we could, is we use the day-to-day practices and the way people are working to be the evidence for accreditation. And so we bring the two worlds together. And so we don't end up with people thinking this is an industry, this is what we need to do and this is what we want to do. People actually see it as the same thing because their quality and safety work every day, they know they can use when they come to their accreditation conversation. Now, I think that's the other maturity we need in the system between agencies like ourselves and yourselves and the Commission, the Australian Commission, about how we do that. But I think there's a will to get into that because it's our job to make it easy. So maybe just two reflections. One is I think the primary care space is opening up, and it's really interesting that the primary health networks and general practice are now knocking on the door, and they want to extend the safety and quality conversation out there. I think data, as well as being a clinician, I'm a development practitioner at heart, and data's the best dialogic tool you'll ever get. It's the best way to start a conversation. So, the more we have it, the more we can use it to change the conversation. If we need to move away from anecdotal discussion to one that's evidence-based.
Carrie, I'll draw this to a close. Thank you very much to you. Thank you very much indeed.
Thank you.